Started. So the first topic today we are going to do is basically hypertension. So hypertension in pregnancy is one of the very important topics. So you need to understand what is hypertension. There is four type of concepts that you need to get from this topic. So let's start from the first one. What is the first one? Hypertension. So what is hypertension? Pre-existing hypertension, like somebody is presenting with you, if she is pregnant or not pregnant, she already has hypertension. And when we label it as hypertension, when SBP, like systolic BP, is more than 140 and diastolic is more than 90. So this is called pre-existing hypertension because she already has hypertension. And now we have to label it at which particular time period that we set. After that, it's going to be gestational. And before that, it's going to be hypertension, pre-existing hypertension. So for that, we label it as before 20th of the week. We call it as pre-existing hypertension. Here, this is mentioned here. After 20 week, it is called gestational hypertension. So you need to know after 20 week what it is. It's gestational hypertension. And before 20 week, it is basically pre-existing hypertension. So pre-existing is basically some female is coming at 7 week, 4 week, 3 week, or even 19th of the week. She is already hypertensive, or she might give you the history that I was already hypertensive and I was taking this medication and all those stuff. But when comes the gestational, she particularly started this hypertension after 20th week of gestation. So, and when we are going to label it, when the BP is more than 140, 90, then should be elevated at two different occasions. It should be at least two different occasions. Like she checked it at home. Now she is coming here. So there are two different occasions. Maybe she came here for the first time. You cannot label it. So you have to ask her to come back again, or you have to ask her to go to nearby clinic whenever she has time. So when there is high blood pressure at two different occasions, then it is called as pre-existing hypertension or as hypertension in both the conditions. At least 15 minutes apart. It should be 15 minutes apart. Okay. So it's not like somebody came to your clinic and you did the hypertension. After 5 minutes, you're repeating it. No, you have to ask that patient to sit for 15 minutes and then repeat hypertension. Maybe she's running, and maybe after that the BP is high. So you have to make sure in the two settings that it is high. So essential hypertension is associated with the increased risk of gestational hypertension, abruptio placenta, IUGR, and IUFD, like fetal demise and growth restriction. So obvious symptoms of hypertension is pregnancy, right upper quadrant pain, headache, and visual disturbances. So sometimes what happens is in the pregnancy, she might not present with a high BP, but she might have these kind of symptoms. So you have to look into these symptoms, and on the basis of that, she might check high blood pressure, and then she has high BP. Maybe you didn't think of high BP first. She might present with headaches, like she's having a lot of headaches. So you thought of, okay, let's do BP. So you do BP and you find out this is hypertension. So these could be the symptoms that she could present with: pain, headache, and visual disturbance. Then this is gestational hypertension, as we already discussed. After 20th week, it will present. But on the same time, you have to differentiate when it is gestational and when it is preeclampsia. So preeclampsia, here it is not without proteinuria. Some people, what they do is they mix up preeclampsia with, like if somebody is coming with a high BP and has proteinuria, it is preeclampsia. No, proteinuria is definitely should be present there. But if somebody is not having proteinuria, still any other organ is damaging, like any adverse condition, or see, it's written with new onset of proteinuria or adverse. So it could be either this or either this. So it is not important that she might present with a proteinuria. If she is presenting with high BP and presenting with visual disturbances, maybe presenting with headaches, maybe presenting with something else like pain in abdomen, so it could present with anything like this. So it could be labeled as preeclampsia. So you need to know the differentiation between the preeclampsia when it's just the proteinuria is not the preeclampsia. Okay. And then comes the eclampsia. Now, what is eclampsia? So when is it called eclampsia? Eclampsia is basically the occurrence of more than one generalized convulsions or coma. So when the already existing BP, proteinuria, everything happens, now she has convulsions as well. So on the basis of those convulsions, you will change the diagnosis from preeclampsia to eclampsia in the setting of preeclampsia and in the absence of other neurological conditions. So one of the questions that I saw somewhere was this, like a 35-year-old woman came to you after 20 week of the gestation. She has she has been labeled with a gestational hypertension. Now her BP is 200 by 80 or 90 something. So now what are you going to start with it? So some people will start with MgSO4, but MgSO4 is to prevent from the conversions. MgSO4 is not something you can start right away because her BP is 200, so she might have the problem of conversion. First control BP, then control the conversions. We will talk about it in the treatment. Clinical manifestation of the eclampsia is basically eclampsia in the clinical diagnosis, typically tonic-clonic, and for lasting for 60 to 60 75. So this is a whole clinical presentation of eclampsia. So everything is written here. Symptoms that may occur before the seizures include persistent frontal and headaches, blurred vision, as I already told you. Any of these features could present, because this is what is happening is adverse. Any organ is getting damaged here. So it is basically blurred vision, headache, photophobia. So your vision should be cleared when they are not giving you proteinuria. It could be still preeclampsia. Okay, proteinuria is not just the only feature that could present in preeclampsia. Okay, in up to like third of the cases, there is no proteinuria or blood pressure is more than 140. So sometimes BP is very high and she is already having eclampsia. But at the same time, when you check the urine, there is no proteinuria. So proteinuria is not something you can label, yeah, there should be proteinuria. Like most of the time they give you proteinuria, but it doesn't mean that it should be there. Okay. So you need to know that proteinuria could be not present in this scenario. That's what I said. You need to know each and every feature, so you could be able to tell if one of the feature is missing. You could still label it, yeah, this is what I read, and this is what the treat or diagnosis is. Okay, so prior to the seizures in general, women with the typical eclamptic seizures who do not have a focal neurological deficits or prolonged coma do not require diagnostic evaluation, including imaging. So if she is having eclampsia 1 year, so it's fine. You don't have to go for CT scan or, because CT scan already has its adverse effects. So you are not going to jump into and rule out subarachnoid hemorrhage and stuff like that. You can still wait for it. Maybe she can get better with the medication. So you don't have to go jump directly to doing all this unless she started having some kind of paraplegia, some kind of numbness. Then you start thinking, yeah, there might be something underlying going on. Now I need to do. Even that, at that time, you're not going to do CT scan. You start with MRI because this is pregnant woman. Risk factors for the hypertensive disorders in the pregnancy: maternal is basically primigravida, diabetes mellitus, hypertension, renal insufficiency, obesity, antiphospholipid syndrome, thrombophilia, and a maternal age is either very less or either very more, like high. Like less than 18 or more than 35. Previous stillbirth or intrauterine fetal demise, vascular or connective tissue disease, fetal factors, IUGR, oligohydramnios, GTN, multiple gestational fetal hydrops, Miller syndrome, and abruptio placenta. Then comes the clinical evaluation of hypertensive disorders. So everything is written here, how you are going to do. As I said, first thing first, what are you going to start with? Non-invasive procedures. You're going to check for the weight. You are going to check for all those visual symptoms. You are going to ask for everything in the history. Maybe you can ask so many things in the history and exclude particular diseases in the history. So always start with the non-invasive. Then obviously when you are going, everything in ops does revolve around mother and fetus. When you are evaluating mother, don't forget about the fetus. Sometimes people, what they do is they check everything about the mother, but they forgot about the baby. So you have to do mother and particularly baby as well. Let's suppose they ask me to write down two things about what are you going to do next. So what I'm going to do is, one thing should be from the mother and one thing should be from the baby. So I have to do it both ways. So it is like I'm thinking in the both directions, right? So what you are thinking, you have to uh, give that particular person about your vision, that what you are thinking. So in your answers, you are representing what are you going to do. So make sure you choose the most appropriate ones, or make sure you choose the most best ones, and make sure you choose anything that could save the patient. If there are two of them, if there are baby and mother, so you have to choose those things which are both safe for the mother and for the baby. So evaluation of the mother is important, and at the same time evaluation of the fetus, like fetal movement, fetal heart rate, ultrasound, BPP, and Doppler flow studies. So these are particularly applied in any of the scenarios which are having this kind of problem. Then the laboratory evaluation, CBC, PTTI, and obviously you have to rule out all those blood-related problems. ALTST, because might be HELP syndrome is going on underlying. So creatinine, uric acid, 24-hour urine collection, PIGF, And PIGF is basically placental growth factor, is an early screening test for the suspected preeclampsia. Okay. So on the sidebars, these are very important. Don't forget when you are reading anything from here, don't forget these ones. These are important as well. So eclampsia prior to 20 week is rare and should raise the possibility of the molar pregnancy. Okay, so this is important. If a pre-eclamptic or eclamptic patient is coming, obviously we label that it's coming at after 20 week. Now, if it is coming before 20 week, what it is molar pregnancy, GTN, GTD, something going on, antiphospholipid syndrome might going on. So you have to think in that direction. You cannot label it as eclampsia or preeclampsia. You have to think of maybe antiphospholipid syndrome, maybe molar pregnancy. But on the presentation of that, and when you are doing all of these diseases, make sure you go to Google and take out their ultrasound and take out their x-rays or whatsoever is available on the Google and see the pictures with it. Sometimes they give you a history, and on the basis of the ultrasound you might be able to tell, yeah, this is what it is. So you can choose the answer right away. Okay, so for the how the baby of the hypertensive mother look like and the ultrasound, go check the Google. There is a lot of ultrasounds that is like very nice ultrasounds are there, so go and check them. Then hypertension, adverse effects of the fetus, everything is written here. Okay. So this one here is the diagnosis evaluation of the hypertensive mother. So what are we going to start with? BP. Korsakoff phase 5 should be used to designate the diastolic BP. Calcium supplement should be given with a low dietary intake of the calcium. Preeclampsia among increased risk and low risk of ASA. Basically, aspirin is going to start. So we are going to start with aspirin if somebody has antiphospholipid syndrome. So we have to start with the aspirin, or maybe having preeclampsia. So we can start with the aspirin. is recommended until delivery. So we are going to do Doppler velostometry because we have to check if the blood flow is properly reaching to the baby or not. Because most of the time, hypertensive babies IUGR, basically growth restriction is going on. So you have to do the Doppler. So you have to see maybe the baby is receiving enough blood, enough nutrition. So you have to rule out all of those. Initial hypertensive is basically several hypertension to be given. What is started with labetalol, nifedipine, hydralazine, mostly started with labetalol. Once you start with oral, or maybe you can start with IV, whatever is needed. So at that particular patient, if she can tolerate oral, why not oral? If she can not take oral and she is having vomiting and stuff like that, then you can start with IV. So initial hypertensive for the non-swear should be methyl dopa beta as the same labetalol. So this is important. If somebody is coming with a very high BP, you are not going to start with MgSO4. You are going to start with a labetalol as per needed. But if she is having a risk of convulsions and she already had a conversion, now you are going to give MgSO4. Okay, so it is important when you are going to give what kind of treatment. Antenatal corticosteroids for the fetal lung maturation should be given all the women preeclampsia before 34-week gestation. Implant vaginal delivery with unfavorable cervix, cervical ripening should be used. So in unplanned, so you have to do first ripening and then do all that. So then oxytocin should be given. Magnesium sulfate is recommended for the first line treatment of eclampsia. Eclampsia comes only when there is convulsions, not before than that. Magnesium sulfate is recommended eclampsia. Prophylaxis in spare eclampsia. And when are the prophylaxis used? When she already has the history of that. Okay. Then comes the complication. Complication is basically liver and the renal dysfunction, eclampsia, severe eclampsia, abruptio placenta, all of these complications, failure, DIC, HELP syndrome, stroke, IUGR, prematurity, abruptio placenta, IUFD, and then HELP syndrome. HELP syndrome is basically hemolysis that we're talking about, elevated liver enzymes and low platelets. Management. Here comes the management. Management of hypertension is different. Management of preeclampsia is different, and management of eclampsia is different. So these were the things that were mentioned in the group today, that how we are going to approach this. So everything is written in MCC objectives very nicely. If you click on that, they'll tell you what you need to start, what you need to study, and how you make concepts. So in that, they were said that you need to know hypertension with eclampsia, hypertension without eclampsia. So only hypertension is studied. You need to know make a concepts about hypertension. Then you need to know hypertension with eclampsia and without preeclampsia. So for the starting of hypertension, for the non-severe hypertension, target is basically BP of 130 to 155, 80, 105 in BP with the comorbidity. So at this particular time, if the BP is 130 or 155 and 80 or 105, but without comorbidities, but at the same time, or If the BP is less than 140, like here it was labeled as 155 or one more than 130, but here it is, if this is less than 140 but with comorbidities means having any nephro problem, having any maybe already underlying like diabetes, hypertension, like already underlying pathology going on, then we are going to start with what, labetalol as per needed, then nifedipine and methyl-dopa. For the severe hypertension, if the BP is less than 160 and as diastolic is less than 110, give one labetalol. If labetalol is not given, then you can move on to the nifedipine. And as soon as the patient stabilizes, move back from IV to oral. You cannot give oral for the prolonged period of the time. If she needs IV, you have to give IV right away. But if she is taking IV for very long period of time, or now she is stable, what you can do is you can switch back to oral here. Let's switch back to oral. Nifedipine immediate, hydralazine, no ACE and herbs, as it is teratogenic, you already guys know. Diuretics, because it can cause pulmonary edema and the cardiac failure may be used. Prazosin or atenolol. Pre-existing hypertension and gestational hypertension without any deterioration can be followed until 37-week gestational age. Then decide to induce shortly thereafter. So you can maintain the pregnancy up to 37 weeks. Then comes the preeclampsia. As preeclampsia already has an underlying pathology going on, any underlying damaged organ is going on. So what are we going to do is we are going to check either the baby should be in the belly or either baby should be delivered. Which one is safe for the baby and for the mother, especially for the mother. If stable, no adverse effects, then you can obviously go with expectant. You can counsel the mother, don't do this, don't do that, try to maintain your weight and blah, 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 everything, right? But on the same time, if the baby is 34 to 36 week and even 34 to 36, then you are going to do expectant management and delivery, because you are going to see because we are going to save the mother. Our main priority is the mother, right? But if the baby could be saved, is as best as it could be. So must risk of the fetal prematurity. So we have to give with the antenatal corticosteroid. So here, if they ask me if the preeclampsia mother is coming on and she is in the very bad condition, what are we going to start with? Corticosteroids. Because if she's less than 35, as we already discussed this, if they're less than 35, what are you going to give first? Anti-corticosteroids. Not just jump directly to labetalol. Labetalol is needed for the BP if they ask particularly about the BP, but if they ask about something else, so you have to check what they're asking, right? Maybe they're asking about what you are going to give for the baby. So make sure what they're asking, you make sure, and then on the basis of that, your answer will change. So if more than 37, obviously delivery is going to be recommended. For the severe preeclampsia, stabilize the liver regardless of the gestation. If she's coming with 25, 28, 29, swear you have to stabilize and deliver it right away. If severe preeclampsia during labor, it needs increased maternal monitoring, like overly input, output, like input, out meaning giving IV fluids and urine that is coming out. Overly neurological, because maybe having something, maybe subarachnoid hemorrhage could happen. So you have to check overly neurological problem, any numbness, any weakness of the body part. Along with it, as we said, fetal heart rate monitoring. If you are checking mother, you cannot miss the baby. Antihypertensive therapy, what is that? Seizure, we are going to start with the magnesium sulfate postpartum management, because postpartum management up to like 6 weeks, roughly, it could stay. So risk of the seizure highest in the first 24-hour postpartum, continuous support for 12 to 24 hours after delivery, and vitals like up to like 1 hour, and consider HELLP syndrome, it could be. So most return to the normotensive within 2 weeks. So management of eclampsia, it is basically, obviously, she is having something convulsions, which is something very, very dangerous. So we are going to start with A, B, C, then roll the patient. So this is basically comes in the particularly in emergency. She's not going to coming in the clinic and having convulsions, right? So she's going to be coming in emergency. So starting from what? A, B, C. Whatever the scenario tells you, whatever it says, if the patient is coming in emergency, your priorities change from anything else to saving that particular patient. So it starts from ABC, roll the patient into that. So here we are going to do everything as we do for the patient of the seizures. So roll the patient, give oxygen, antihypertensive therapy, because BP is very high. So recurrent convulsions may cause the seizure activity repeatedly, rhabdomyolysis, metabolic acidosis. So this is important. You need to know what convulsions can cause. Rhabdomyolysis, metabolic acidosis, aspiration, pneumonia. The first line. And what are we going to do is delivery. after maternal stabilization, irrespective of the gestational age, to reduce the risk of maternal morbidity, mortality from the complications. Mode of delivery is dependent on the clinical situation and the fetal maternal conditions. So here, this is iron deficiency and folate deficiency. You can read it how you are going to give iron and how are going to give. So mostly it is started in the prenatal counseling and then natal counseling. So we are going to give prevention for the iron and folate. Then is diabetes. Diabetes is very important. So that's why I want to cover this one. So hypertension, in hypertension, IUGR, okay? You cannot miss this word. When you are reading hypertension, the baby mostly present. I'm not saying every time, but mostly it presents as the IUGR. Hypertension is linked with IUGR, but diabetes is linked with macrosomia.
Macrosomia.
Yeah. So you need to know both of these words. So when you are giving with the what is the most common complication of what hypertension? So you have to choose IUGR. But make sure when I'm saying this, it is not applied in every condition. So you need to know what they're asking, what they're saying, and then on the basis of that, your answer can be changed. Why I'm saying this again and again, because I have seen a couple of scenarios which change because of the wording. So make sure you know what they're asking, and on the basis of that, you can choose the answer. Okay. Then comes the diabetes. Diabetes is basically type 1, type 2, and then gestational. So everything is written here just like the same. Then comes the management. Obviously, if somebody is already having diabetes, you are going to start with insulin. If they're saying then you can start with continuing glyburide and metformin, but it is controversial. So stay on the safe side, which is basically giving insulin. And for that particular patient, you are going to give folic acid on very high doses, at least 3 months prior, and then glycemic control should be present. So you need to remember these. This. I know it's kind of hard to remember the values, but you have to remember it. This is like something you should remember on fingertips. So you know when should be the 1 hour postprandial value, when should be the 2 hour postprandial value, what is the fasting plasma glucose, even not just for that diabetes of the pregnant female, but on the other side as well. It is written on the endocrinology. It's very written nicely. Little small table is right there. So you can read it from there. So you need to remember these values on the fingertips. Then comes the pregnancy. What is pregnancy? For the type 2 diabetes mellitus, switch to insulin, as they said. And then tight glycemic control, insulin dose may be needed to be adjusted as the pregnancy advances due to the increased demand. So you can change the insulin dose, even insulin, thyroid. So you need to know which kind of doses should be changed when there is a pregnancy, and why. Why these doses are changed. Those all particular things, what is raising and what is increasing, it's written in the start, so you can read it from there. Postprandial blood glucose value seems to be most effective at determining the likelihood of macrosomia. See what I was talking about. Monitor as for the normal pregnancy plus initial 24 hours urine protein and creatinine clearance, retinal exam. So you have to check for everything. Urine, creatinine, because you are going to rule out if this pregnancy is going to be normal and if there is an underlying pathology because of the diabetes is going on, if she is already diabetic. So you, in the very start, you are going to do all of this. It is not done in every particular patient, but it is done in most of the patients. Like I'm saying, if a simple woman, like simple woman means like somebody who's not having this diabetes, she's coming to do. Are you going to start with the urine protein and creatinine? Obviously not. So you are going to start with the same all those basic needs, right? But if that particular woman has diabetes or hypertension, so her test at the very start would be different. So you need to know if that particular woman is diabetic, what are those tests should be done, and if that particular woman is coming with hypertension, what her test should be. So those tests might be little different, so you need to remember those one. Here you are going to start with the retinal exam, HbA1c, fetal surveillance like fetal growth, PPP, NST starting in late T2, T3, fetal echo in the T2 to look for the cardiac abnormalities. Then comes the labor. What are we going to do with the labor? So once the placenta expels out, what happens here is insulin levels start decreasing. The requirement of insulin start decreasing. So you have to check those things. Okay. The timing of the delivery depends on the fetus and the maternal health, and 38 to 39. So you need to check if it's uncomplicated, induce earlier, if indicated, like if it's complicated. Then pelvic disproportion because baby's macrosomia. So on the basis of that, we have already read it. Like if more than 4,000, what are we going to do? And if they're more than 4,500, we are going to do CD monitoring. So that's what I was already said, that insulin and dextrose should be checked every, blood glucose should be checked every 1 hour. Okay, even in the normal DKA or HHS, we check glucose level continuously. This is the same because this is also a complicated condition. So we have to check the blood glucose level every 1 hour. One of the blood glucose should be 4 to 7 millimole per liter to reduce the risk of neonatal hypoglycemia. This word, this little word, I don't know how should I say, but this little two words is, is carrying so much weightage that you need to remember these two words, and you cannot just enter the exam without knowing that a diabetic mother has neonatal hypoglycemia. Okay. Then comes the postpartum. Insulin requirements dramatically drop with the expulsion of placenta. As the placenta comes out, the need of the insulin decreases as well. Monitor glucose every 6 hours and restart insulin at 2/3 of the pre-pregnancy dosage if the glucose is more than 8 millimole. Then the screening, you need to remember these ones. So there are two type of it, OGCT and OBPT. So remember that these are two different, not just one. Okay, this is OGCT and this is OGTT. Little difference, but you still need to remember. This is hardly like done, but it is very accurate and it's mostly done. Hard to done is basically because it's fasting blood glucose. If that mother or that particular female is having hyperemesis gravidarum or vomiting, so it is kind of hard to done on that particular female. But if she's normal, then you can do it. But on that cases, if she's having hyperemesis gravidarum or she's having nausea, vomiting, what are you going to do is OGCT. So this is basically alternate of those. These are two different ones. So you need to remember these values. Okay. Then comes the management. Obviously, diet management. Non-invasive comes first. You have to tell about the physical activity. And if the diabetes or that value is very high, fasting blood glucose, what are you going to start with? Initiate insulin. Oral is started but is off-label and should be discussed with the patient. Stop insulin, diabetic diet postpartum, follow-up between 6 weeks to 6 month postpartum, counsel about lifestyle modifications, serial BPP, and growth starting at the 28 week, like every 3 to 4 weeks, you have to check the baby if the baby is going towards a macrosomia. Then starting at 36 week and the fetal well-being and BPP, MST until delivery, induction of labor between 38 to 40 week gestational age. So these are the risk factors, so you need to remember them. Then prognosis. This is something I want to highlight here, these two here. You can remember rest of the stuff by yourself. It's not that difficult, but this is little different, so I'm going to highlight here. So here, look at this one. End organ involvement or deterioration occurs in type 1 and type 2, not in gestational. Because type 1 and type 2 is present in the first trimester. So in the first trimester, what is happening? Retinogenesis, right? So that's why the end organ damages in maternal, it's different because I'm talking about organogenesis in this one. But if talking about maternal, because it is already present there. So gestation comes after first trimester, so it stays for 2 trimesters, hardly like 6 months, right? So it is not going to cause retinopathy or nephropathy, because to cause retinopathy and nephropathy, diabetes should be there for at least more than 1 year or 2 year or 5 years, right? So those are different. But it is not happening in non-gestation diabetes. Same goes for the fetus. So in the fetus, the congenital anomalies occur in type 1 and type 2, but not in the gestational diabetes. Okay, because organogenesis is happening in T1 and gestational diabetes started after 20 weeks. So basically in T2 and T3. Okay, 2 to 7 time increase in the cardiac, GI, musculoskeletal disease, and the pregnancy is complicated by the gestational diabetes, do not manifest as increase congenital anomalies because gestational diabetes develops after the critical period of organogenesis. Then comes the labor, delivery, neonate. So you can read it. This neonatal, what are the complications that is present? Hypoglycemia, hyperbilirubinemia, hypocalcemia, polycythemia. So then is one of this topic, I think we have little bit of time, so we can do this. This one is important, this indications. Just, I don't know, just remember it. Like you should know these on fingertips, this thing. Because I have seen couple of MCQs here and there. So it is something which is, I would say that don't miss it. Indications for the intrapartum antibiotic GBS prophylaxis, prevention of the prenatal group B diabetes, streptococcal disease, Previous infant with invasive GBS, if somebody already has a delivery or had a pregnancy but had the GBS as well, so in the next you have to give antibiotic until proven otherwise. GBS bacteriuria during trimester, you have to give the antibiotics. Positive GBS vaginal rectal screening culture in the late pregnancy, gestation during the current pregnancy, you have to give. Unknown GBS status, that you didn't do any test and you are not sure that if she is positive or she is negative. Delivery at less than 37-week gestation, amniotic membrane rupture more than 18. Intrapartum temperature is very high, like she already has been unsuspected temperature going on, so she might have GBS, right? So you have to play safe. Intrapartum nucleic acid, and it came out as positive. So all the risk factors are written here, and then clinical, and then investigations. What are the investigations? Vaginal and anorectal swab for the GBS, which is basically NAT testing. Then what is the treatment? Prophylaxis, basically penicillin. Penicillin is safe to give in the pregnancy, so you can give it IV 4 hours until delivery. Penicillin allergy, but the low risk of anaphylaxis, like if patient has penicillin allergy and her risk is very high, so she might have allergy with the sphazoline. So you cannot give sphazoline if some female having penicillin with a very high allergy, right? So if she is having allergy but low risk of anaphylaxis, you can switch the penicillin to sphazoline. But she is having high, so you have to switch to vancomycin or clindamycin until proven otherwise. Then vancomycin and clindamycin levels in the amniotic fluid do not reach therapeutic level. All babies should be screened for the GBS. If the maternal have fever, broad spectrum coverage, GBS status, GA is advised. So it's less than 37 in the labor or in the rupture of membrane, IV GBS antibiotic prophylaxis of the minimum 48 hours should be given. So I think we will cover our